So I was asked to just give some opening comments and some perspective. As many of you know, I've been on a number of the writing committees for the American Heart Association and American College of Cardiology, and I wanted to kind of take you through where we started. This is actually the second SHAPE guideline. It's fairly similar to the first in many ways. There's a few tweaks to it, but basically almost a decade ago now, this concept of risk stratifying with imaging was born largely under the guidance of Dr. Nagavi, as many of you know, and really was greeted at first with, some would say, great resistance. There was a great opposition to the concept, and I think what I'll show you over the next few slides is that the guidelines have continued to move towards even the original SHAPE algorithm that was put forth so long ago. So this is from Dr. Grundy from NCEP. This is from the NCEP-3. So this was published in 2003. They said calcium is an option for advanced risk assessment, and a person with multiple risk factors, high scores denotes advanced coronary atherosclerosis and provides a rationale for intensified LDL lowering therapy. So put it out there as an option for advanced risk assessment without making a formal recommendation. 2006, the American Heart Association, for the first time in at least a decade, came out with a scientific statement on cardiac CT. And it said that cardiac CT improves risk prediction, especially individuals determined to be at intermediate risk, according to NCP-3 criteria. So, of course, the most important part of this is in whom decisions concerning preventive strategies may be altered. So it's important to realize the concept that we're not just saying everybody should be tested at this point from the American Heart, but rather when we can modify what we do. A year later, the ACC and AHA weighed in on the clinical expert consensus document on calcium scoring and said with a 2B recommendation, a fairly modest recommendation at best, may be reasonable to consider use of CAC in patients based on that demonstrates incremental risk information in intermediate risk patients. It's a fairly weak recommendation in 07. So since 2007, and I'm going to digress to one study in 2005, the St. Francis Heart study, but since 2007, there's been a robust amount of data that's come out, and then I'll show you the 2010 guidelines, which basically largely conform to the SHAPE algorithm. So the St. Francis Heart study came out for the first time, a large population-based trial demonstrating a 10-fold increased risk of having a heart attack or sudden death. So on the far right, that yellow bar, 9.9-fold increased risk of MI or sudden cardiac death. So calcium scoring imparted a 10-fold risk. As many of you know, CRP did not work. I think there's a full table up here, guys, empty, if you want to. CRP imparted a 10-fold risk. And part of that trial, and probably the most important part of that trial, was what I call the precursor to Jupiter trial. This was a very similar type study, the Jupiter type trial, the St. Francis randomized trial. This randomized 1,000 patients to atorvastatin 20 or placebo and followed them for cardiovascular events, and resulted in a 42% event reduction if they were treated with atorvastatin. It wasn't pure atorvastatin. They also added vitamin C and vitamin E. Back in the days, this was the late 90s, when we still believed antioxidants had a role in cardiac disease prevention. But nonetheless, a trial that demonstrated that if you have a high calcium score, you can treat that person and impart some benefit. The trial was limited by its power, was limited by the idea that antioxidants would add further value. And that was reinforced by long-term data that I published in 2007, again showing a calcium score of 0 imparts a warranty period of about a decade where you do not, you have a event-free survival, or at least survival, over a decade with a score of 0, and a score of 100 imparted a 10-fold increased risk. So you're 10 times more likely to die over the next decade. But the two trials that changed the guidelines significantly, the first one published was MESA. MESA was 7,000 patients. This was just 3.5-year follow-up published in the New England Journal of Medicine, but showed us the same thing we've seen over and over again. If your calcium score is above 100, you're 10 times more likely to suffer a cardiac event. And if your calcium score is 0, you're unlikely to suffer a cardiac event. So we can stratify risk and therefore to dictate therapy. Followed by the Heinz-Nixdorf recall study a year later. This was reclassification published in JACC last year, showing that if you have an intermediate risk population, about 1 out of 7 get upclassified. They're not intermediate risk, they're high risk. And more importantly, maybe, more than half of the patients are reclassified to lower risk. And we'll hear more about this tonight. But a very important concept, the Rotterdam study also showed 50% of patients in this intermediate risk population are reclassified. So we can improve upon Framingham and deliver better care. And we know which care to deliver. We at least have data that statins lower cardiac events. So observational data from MESA shows us that we can reduce the number needed to treat, I'll show you in a moment, reduce the number needed to treat dramatically by adding something like a calcium score to our algorithm. And of course, in all of these studies I showed you, almost all these studies, CRP added little or no value. The only study that added value in actually was the recall study. The other studies, it didn't work to add value. ERIC data showed us data that patients can be reclassified with carotid IMT as well. And again, a robust number of patients, over a third of patients, reclassified from that intermediate risk category, either higher or lower, depending on the results of their IMT. So really important data to show us that imaging can help. The whole premise of calcium scoring, of plaque imaging. So the 2010 guidelines basically came around and said, yes, the SHAPE guidelines for the large part are correct. They gave a 2A recommendation for testing subclinical atherosclerosis and intermediate risk. A strong recommendation is useful, right? So for both carotid calcium scoring and carotid IMT and plaque imaging. So it gave a strong recommendation for subclinical atherosclerosis imaging in intermediate risk and added something that's been a tenet of SHAPE. The Rose principle that says the larger the population, the more events will occur, even if they're lower risk. That low intermediate risk, that 6 to 10% population, also could benefit from imaging. And that received a recommendation as well. So the recommendations, the diabetes even received, diabetics received a recommendation as well. So the ACC/AHA guidelines now basically, over the last 5 years, have come around to really emulate the SHAPE guidelines. And it's because of data like this, probably the most important study we've had recently, and I know Dr. Berman's going to touch on this, but just showing us that delivering care after imaging could actually save money. So these are patients, remember, 50% of the population has a score of 0, and the actual costs were $1,000 per person lower if they got a calcium score as compared to the no-scan group. We lowered healthcare costs delivering appropriate care to the appropriate patient. So this is cost compared in the zeros to the no-scan group, and it was 37% less procedural costs in follow-up and 26% less medication costs in follow-up. These are patients who we know will not have a cardiovascular event over the next 5 years. So we can save or reallocate those resources appropriately. And finally, I know Dr. Diamond couldn't be here tonight, or Dr. Call, but I think their initial assessment, published in 2007 on SHAPE, was on target. The only assumptions were that a calcium score cost $400. So when they did their analysis, it didn't come out very favorably. And we all know now that Medicare and other payers are in the $100 range, so we can redo their analyses. But if we look at the 50 million patients that potentially would fit in this algorithm, according to George and Sanjay, the calcium scoring would identify the smallest N, the smallest number of people who need treatment, and capture the most events. The event rates would be by far the highest. So we can concentrate our preventive efforts at the people at the highest risk, right? Matching intensity of therapy with intensity of risk. This was their original assessment, that it was similar in price to treating all, and it was cheaper to use the Framingham risk model. So it was a better deal to just do NCEP risk stratification and not do a calcium score. But this whole premise was based that a calcium score cost $400. And if we changed one thing to just a calcium score being $100, which is what Medicare reimbursement is for a calcium score, you can see the costs shift markedly. Same assessments, same expenses, but now the cost shift markedly in favor of calcium scoring and the SHAPE algorithm. You can see $2,000 per year of life extended as compared to $18,000 for Framingham or $23,000 as a treat-all strategy. So a very simple thing to change. So I firmly believe, and this was something that I came to agree with over time as more data evolved, and I think Mort was way ahead of his time when he conceptualized this initially, but I believe this now to be a true statement. The widespread adoption of atherosclerosis tests is expected to save tens of thousands of lives each year and reduce healthcare costs through early detection of risk, matching intensity of therapy with intensity of risk, and it also maximizes compliance, something we'll hear more about from Dr. Berman in a little while avoiding unnecessary tests, right? So we don't have to go on with a score of 0 and potentially do treadmills, nukes, thalliums, or stress echoes in these patients who are otherwise low risk. So I'll leave you with an algorithm that predates even Dr. Nagavi's foresight. This is from 5,000 years ago. This is from the ancient Chinese medical text, the first Chinese medical text found, 2600 BC. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. And inferior doctors treat the full-blown disease. And I'd attest that at least if we can identify subclinical atherosclerosis, treat the disease before it becomes evident, that we can at least move up to the eyes of mediocrity in the eyes of the ancient Chinese from where we are today. And I would argue that most of us, both invasive cardiologists and non-invasive cardiologists, unfortunately spend a lot more of our time and resources treating patients who present with symptoms or with positive stress tests, or unfortunately with full-blown heart attacks or sudden cardiac death. So I'd like to stop at this point and thank all of you and introduce our next speaker.